It's my pleasure. I wish I was there, but I'm not. Inshallah, next year. So I've got 30 minutes, and the title is Improving Stroke Care in Pakistan. This is it's a good topic because you can go almost anywhere with a topic like this. And I was looking at the program, and if I may allow myself some redundancy, and I think redundancies are always okay. But I'll give you my impressions of where stroke is in Pakistan and where it needs to go. And I'm not an expert, but I've been to Pakistan over since 1989 when I started my stroke career. So it's been almost 32 years now. I have no disclosures for this presentation that are relevant. I have my outline as the following one. I want to talk about where the essential components are in the stroke program that makes it successful. And there's a very good publication out yesterday from the World Stroke Federation, published in the International Stroke Journal, which I'll encourage you to read, which talks about stroke care in different parts of the world. So I'll share a few slides from this research. And then I'll break my presentation very quickly where the importance of primary, secondary stroke care is, and also ended by talking a little bit about acute stroke care. So in our programs and in my province here, I believe the most important part is this clear designation of various hospitals and their preparedness of managing stroke. So in a city as large as Karachi, or you could be in Quetta, or you could be in Islamabad and Rawalpindi, you cannot have all hospitals doing everything. It's just impossible. My city where I am right now is Edmonton. We have 6 large hospitals, all teaching hospitals, but we have designated 2 hospitals as our stroke care hospitals, and just 1 which is comprehensive. Comprehensive means that you can do thrombectomy 24 hours a day, and you have neurosurgical support available in case something goes wrong. So most importantly for the planners, when you're living in a large city, and Karachi is a good example, you may want to have 2 or perhaps 3 hospitals, which are your stroke designated hospitals. And that's critically important because when a patient is picked up, they need to go to a hospital that has facilities such as the rehabilitation that Dr. Rathore just presented on, excellent presentation. So integration is important, and your personnel are also very important. There is a serious risk of harm. Most stroke patients that come in tend to recover, but if they have complications in hospitals, they don't do well. So services like good nursing support, a stroke unit, therapists like occupational and physio and speech pathologists are essentially important. If you're a comprehensive center, you need to have a stroke prevention clinic, you need to have a stroke unit, you should have facilities for thrombolysis as well as thrombectomy and rehab facilities. And if you're going to do thrombectomy, you need to have excellent imaging or even thrombolysis or stroke diagnosis. And I'll talk a little bit about that. I think registries are essential, and I'll talk about it a little bit more in what is going to be your morning tomorrow. So it's your evening right now, and it's very early for me here. So the presentation, this was just published yesterday. It's the state of stroke services across the globe. And what is disconcerting is that stroke units, which are present in all hospitals, more or less, in high-income countries, are less than 20% in low-income countries. And what struck me as, I mean, this is data, I'm only looking at it, it may be accurate or not, but it's out there, it's published. What was disconcerting was this thing, look at quality performance surveillance of how you're doing. This is a little disconcerting that Pakistan is part of just 4 or 5 countries with this absence of data. And that's not good. I mean, we are a big country, and we should be able to provide this kind of data. The other thing that came out of this survey is that if you look at surveillance, prevention, acute stroke, and rehabilitation, South Asia is not doing very well. In fact, it's one of the lowest in all of these countries that were surveyed. So the surveillance is important. You want to know how many strokes are you getting, how severe they are, what's your mortality, etc. That was 30%, and acute stroke care was available only to a third of the patients, and a quarter got a rehab, right? And again, if you look at preventative strategies, extremely important. Stroke prevention activities are, so for Pakistan, it comes in the poor category. You know, that is worrisome. So that's kind of part of the reason where I want to start off with primary prevention. And when you look at primary prevention, I am sure most of you would agree with this. These are statements I've been using for the last 25 years now, that the outcome of a patient with a treated stroke would never be as good as that of someone in whom you can prevent a stroke, right? I mean, I can show you examples of full recoveries with big clots in their MCAs, but the key thing is to prevent a stroke. And you'd also agree that it is better to be healthy, right, than be dead or ill. And that's the argument. You can't make a better argument than that. A stroke is not a disease that kills you. Stroke disables you, right? And we know quite a lot. We know a lot about the risk factors. The ones that we can work on. I mean, there's lots of risk. Age is a risk factor. You can't do anything about it, right? So we focus more on modifiable risk factors. So if you look at modifiable risk factors, I mean, the diet is important, and we spend a lot of time on that. And our diet in Pakistan is as bad as it can be anywhere in the world. But diabetes, smoking, hypertension, hyperlipidemia are the ones that has at least good evidence that we can put strategies in place where we can correct a lot of them. So this is where I'll talk. There are very high risk categories. You need to recognize atrial fibrillation. You need to know if there is carotid stenosis, and it's a whole long discussion whether we should or shouldn't treat asymptomatic stenosis. But what I wanted to share with you is an interesting paper. It's getting old now. It's almost 80 years old. This was done from, most of the researchers are out of Aga Khan University, and they published it in Lancet. And so this came out about 8 years ago, which talks about health transitions in Pakistan. It's very informative, and I just want to spend a few minutes going through this. So what they looked at were various types of accidents, various types of diseases. So here's, for example, road traffic accidents. Burgundy, this is where I want you to concentrate on. Cardiovascular diseases, and cerebrovascular is buried in here. So the first thing you see, so the two things they did were they looked at what they could find in Pakistan from 2010, and then they extrapolated where things would be 15 years later. So what they were looking at in vascular diseases, they broke it down into age groups, less than 30, 30 to 69, and more than 70 years of age. And this is no surprise to any one of you. As we grow older, our risk of vascular disease increase. And if you compare 2010 to 2025, you can see that this is going to increase by at least 30% between in these 15 years. The focus then, if you break it down on in this Burgundy area, which is cardiovascular diseases, the biggest impact, and this was a surprise to me, it was tobacco use. Perhaps it's not to you so much as it was to me, because this is totally preventive, right? So it causes chronic respiratory illness, and cancers. But here's vascular disease, hypertension. is more or less all related to cardiovascular disease. And then you can see a decreased physical activity and high cholesterol, etc. And these numbers all increase when you compare 2010 to 2020 and 2025. So the next thing they did, which I thought was very interesting, was that you bring in prevention strategies. So this is primary prevention, right? And you were to look at reduction, and they took an arbitrary figure. They said, well, let's see if we can bring it down by 30%, and then what will happen. So decreasing tobacco use by 30%, you can see what a big difference it makes in preventing diseases, all of them, whether it's respiratory or cancers. But here's vascular disease. I wanted to talk a little bit about hypertension, so I just highlight these for you, that you can decrease, this is less than half, simply by reducing your blood pressure by as little as 3 millimeters mercury. And there's data for that in secondary prevention also. You can have a huge impact, massive impact. And then I was thinking about, how do I teach, and what can I tell you that you can take home with you? And 2 weeks ago, 10 days ago, big noise by the Center for Disease Control in the US, which talks about this factor. So this is from JAMA, Journal of the American Medical Association, which talks about the mean intake of sodium, which is mostly salt, across all ages. And look at how terrible this is. Exceeding a recommendation of sodium, and these are the age groups. So you're going down from very young to old. And you can see in men, which is in some of the orangish color and the blue color. So within the recommended range is in the bottom here. Isn't it terrible? That 94% of men over the age of 60 and 72% of women over the age of 60 are taking in more sodium than is recommended. So if you wanted to take some message home today, this is my first and most important message in here, that if you're going to look for a 3 millimeters reduction in systolic blood pressure, here's your answer. Just don't add salt. I've stopped doing that. I don't add salt in what I eat. And I hope that that would cut me down and bring me in these people in here. So you woke me up early in the morning, which is okay. I even wore a tie for you. But my first message in prevention is the following: cut down on your salt. We eat way too much salt in Pakistan. So when we talk about primary prevention, I've got 2 recommendations and at least one thing for you to think about. The first thing is that you be very aggressive. As stroke neurologists, it is our duty not only to dispense aspirin, but to treat modifiable risk factors. So blood pressure less than 140 over 90, ideally there should be less than 115, 120 or 70, which is what we aim for, and get used to it. Most of us should be using combination medications. My preference is ACE inhibitors with a diuretic, so perindopril with indapamide would be my first line, and then I'd go to calcium channel blockers. Amlodipine would be my second choice, for example. But you need to be familiar. You need to be very comfortable in treating hypertension. And it's better to treat the blood pressures at home and not in your clinic. The second strategy and recommendations, which is very important, at least in our population in Pakistan, because we may consider the lipids not as big a problem for stroke in North America, but in diet we eat and the extremely high incidence of diabetes and metabolic syndrome in our population, we need to keep the LDL low, and we need to keep it very low. So let's concentrate on this bracket in here, the highest risk. Highest risk are patients who have had established atherosclerosis, so most of my patients with stroke or TIAs, or patients with people with diabetes. So this is where you need to bring down the LDL to less than 1.7 millimoles. I'd say 1.4, 1.5 is where we keep ours. And you'd need the high dose. So we start with 80 milligrams of atorvastatin, and most patients, we encourage them to tolerate it. You got to be a little more aggressive with them. So I've been thinking about it, and I was actually talking to or emailing back and forth with Professor Vase that, when you start giving people aspirin and a diuretic and an antihypertensive and a lipid-lowering agent, that just gets to be too many medications, right? But there is some very good data. Here's an example of the polypill. So this is published in the New England Medical Journal by Salim Yusuf and his group, showing that if you use a polypill that contains blood pressure reducing medications and cholesterol reducing medications, you can see very quickly you reduce your blood pressure. So you've gone up from 140 to 130. It's a huge jump, right? And then your LDL cholesterol goes down. And what does that do? They've actually shown that over the years, you can see that the incidence of the first vascular event significantly falls down. And it's best in the polypill that is used together with the baby aspirin. So that's this green line in here compared to those who are on double placebo. So to summarize my primary prevention, public healthcare awareness is very important. And I see the nice work being done across Pakistan with the stroke days in the community and speaking on the media. All of those are very, very important. This in here, public awareness and educational efforts would hopefully improve vascular risk factor management. All right, so that was my first part. This is how I believe you've got to focus on the big grassroots level. Quickly go over secondary prevention. This is where time is quite important. We don't realize this, but in our world, the high risk patients, so I'm in the hospital right now, somebody came in with motor symptoms and speech difficulty and a high ABCD score, we
have three more minutes for your presentation, please.
You're kidding me. I thought it was half an hour. I was given half an hour. Well, all right. You know what we can do is we'll just have to go through. This is not good. Somebody should have said it's 15 minutes. As recently as yesterday, it said half an hour. Well, I'll stop here then. Why don't we entertain some questions? It's pointless to continue.
Yeah, it's fine. It's fine.
Sorry, what is fine?
To complete your talk, please.
Okay, I'll try to go a little faster. But so, so secondary prevention, MR is the way we go. We do CTA and we look for vascular imaging and make sure there's no arrhythmias in these individuals, and we treat them as soon as possible. We basically start treating as soon as they come to our emergency department. We have a fairly large group of preventative therapies. All our patients would go on aspirin plus clopidogrel. Look out, tomorrow there's a presentation at the World Stroke Congress that is called Chance 2. Chance 2 would compare very important research from China, aspirin plus Plavix versus aspirin plus ticagrelor. So the question is this combination better than aspirin plus ticagrelor? I don't know it today, but we'll know it later on today or early tomorrow morning. We don't have Celestrozole available in my practice, but I think you have it available. But these are still the first line treatments. Remember, the clopidogrel is only for 21 days, aspirin's for a lifetime. And any of the direct oral anticoagulants, if you have atrial fibrillation. So the way we see it is that if the person is high risk, TIA, I don't have the time to go into that right now, then dual antiplatelets for 21 days and then stop the more expensive one. So we always continue the aspirin and stop the Plavix. We use single antiplatelets for low risk TIA. So it's the numbness and dizziness where you're not sure. Somebody comes in 7-8 days after they've had their events. For all of these, we would use a single agent. This is an important category. keep in mind that you would see these scans that are being done for whatever reason. Somebody has headache, you do a scan, and you look at the brain imaging, and you see small vessel disease. So it could be periventricular, or you could see an incidental asymptomatic stroke, etc. No one knows today how best to manage them. We focus on the risk factors, but we frequently also would give them baby aspirin. We'd also consider a single aspirin, a single antiplatelet if they'd had recent history of, and it's in the elderly, that's not uncommon, GI bleed or previous history of cerebral hemorrhage. And if the duration, if the symptoms, if they come in more than several days, I put in 7 days in here, after their TIA, even if it's a high risk TIA, because all of this data for dual antiplatelet is in the first 12 hours to 24 hours. I put it in bold for you. This is really important. Try not to switch agents. One of the things that I see constantly is somebody has a TIA and they go on aspirin, and then they have another TIA, and you switch them to clopidogrel, and then not infrequently people start using. I mean, you could do more harm than good in these patients. So there is no evidence that switching makes a difference. They may not be compliant to the medications, or they may have a different etiology for their symptoms. So my third strategy in here is antithrombotic medications are very important for a robust preventive therapy. Use dual antiplatelets for TIAs and minor strokes, which are high risk. And for all other, use single agent. And my single agent almost always is aspirin. That's my other take-home message. Don't go for the more expensive drugs. They're expensive, but they're not better. They're just not better. And avoid switching of medications. And if you do find atrial fibrillation, then the treatment is not aspirin. Actually, aspirin doesn't work. So it has to be anticoagulation in such patients. All right, so finally, the third part of the presentation, which is acute stroke. I'll go quickly over in here. Remember, these patients are very unstable and at a very high risk for complications. So stabilize them. Make sure that it's not a mimic, because you don't want to give thrombolytics to mimics. In our practice, 1 in 2 strokes that come to our emergency department, where they call us, when they call the stroke team, 1 in 2 is not actually an acute stroke that needs treatment. So mimics are very common. And then quickly investigate if there are candidates with thrombolysis or thrombectomy. And then, of course, over time, you want to find out what the etiology is and plan a strategy to prevent recurrences. To tell you how unstable they are and why a stroke patient should not stay in the emergency. That's my third really important message for you. Emergency departments are not prepared to take care of these patients because they're busy stabilizing patients. They don't understand that our patients can have complications. So some time ago, when I was in Qatar, we looked at emergency stay. They had, the hospital was always full, and most patients would end up staying in hospital. And Naveed, who's from Karachi, is in Qatar, had worked on this with me, that if you look at patients who stay under 8 hours, the risk of complications is about 14%. If they end up staying longer than that, this goes up to almost 20%. And you can see that most patients were staying longer than 8 hours. And this is important because this is dependent on the severity of the stroke. In Qatar, most strokes were mild because they were related to diabetes and hypertension and were so-called lacuna stroke. But if you look at the severity, if you look at the NIHSS score, we saw that with mild strokes, there were fewer complications. But with severe strokes, so the stroke NIHSS of 16 or more, you can see that more than a third of them would get complications in the emergency department, which is clearly something you don't want, right? And not only are these complications important to document, but if you look at their discharge, if they stay longer than 8 hours, fewer of them go home with a modified Rankin scale of 2, which means they can be independent. So whether it's a discharge or longer, or at 90 days, their outcome is not good. And all of this is preventable. So get these patients out of the emergency to your stroke unit as fast as possible. Because in the emergency department, they'll get into trouble. So what do? Here's our emergency department, here's our scanner. If we see an ischemic stroke and no hemorrhage, we give them TPA right there. We're actually giving more than 270, 280 patients a year TPA. This is our door to needle time. And as the CT scan is being done, as the TPA, which is right in here, TPA is being given, we do a CT angio, which will give us whether there's an occlusion or not. And immediately following that, we do perfusion imaging. So as perfusion imaging, you can see the core is irreversible damage. The penumbra is in green. It's pretty simple. You can actually measure it. That's the core. In this patient is 4 mils, a very large penumbra to save. So these, let me just skip this. So you can see an M1 occlusion. And if you get in there early enough, you can open it up on the first pass and you make full recovery. All right, so the final portion is on evidence that stroke units save life. I don't want to spend too much time. Dr. Rathore, I had the pleasure of listening to his presentation, did a very good job. That no matter where you are, whether it's in Southeast Asia, South America, Africa, wherever you go, if they've published their data, patients who go into stroke units do better. And part of the reason is that if in your center you admit 100 patients, I'll give you the numbers. Let's say in your region, you have 1,000 stroke patients. And of these, you're admitting about 70% into your stroke unit. Just by doing that, just by preventing complications, you are avoiding 33 deaths. And all you do is you're preventing complications. If you were to give these patients, the number needed to treat is 60, it's very, very impressive. This is very comparable to number needed to treat with TPA, which is 18. And the number needed to treat with aspirin is 77. So stroke units are extremely effective. And any hospital that admits more than 100 patients a year should have, even if it's a 2-bed stroke unit. Here's an example. This is my more or less final slide. When we got to Qatar, so when we published it in stroke, we were very easily, we were able to show very quickly that just by creating a stroke unit, your length of stay went down from 14 days to 6 days. This was only and only because we were preventing complications. See, the incidence of complications decreased from 23% to 6.4%. So the data is shown here, but I don't need to go into that. So I'll just go into my summary slide. Stroke remains, it's an important cause. It's a major cause of disability in Pakistan. And I believe that as I showed you the numbers in my first few slides, surveillance is very important. You need to show more data as to what is happening in the country. Absolutely essential. Something similar or akin to what the cardiologists are doing with their cardiac registry in Pakistan. It's still cost effective to focus on primary prevention, which is not so much a mandate of yours, but if you go out in the public domain and if you give awareness lectures, etc., I think that's where you'll get the biggest bang for your money. It is really important, very important to see these urgent high-risk TIAs and start treatment immediately if you do happen to examine them. Acute stroke remains a problem. I personally think, I'll talk about this later or tomorrow morning, but it is expensive and there's no two ways around it. We continue to struggle and work in Pakistan to provide thrombolysis and access to thrombectomy. But unfortunately, you have a long, long way to go, and it's mostly expense. Somebody sent this to me yesterday. I was so impressed. This is 2 days ago in Peshawar. So this is the World Stroke Day being celebrated. So here is where I end, and my apologies if I went over, but I was told 35 minutes. I'll stop here.
Okay, thank you very much. Any questions from the audience? Dr. Vase has got a question.
Shuaib, thank you very much. What happened? Do you have any idea that we were planning a study to do streptokinase for acute stroke patients? So you just dropped the idea, or is it still somewhere in the process? That's my question one. Number two, for the developing countries like Pakistan, you have suggested that a concept of polypill would be a better option because a lot of people cannot afford a blood pressure medication, a cholesterol medication, and antiplatelet. So maybe if you just combine these three medications in one pill, and that's made available at a cheaper cost to a deserving population. So do you think like these ideas still are practical, and I think they could be done in Pakistan? We need like more pilot projects or something like that. And how can you help us, especially Pakistan Stroke Society, in implementing those ideas into execution and bringing something meaningful to this country?
Assalamu alaikum, Wasi. Always nice to talk with you. You've been such an excellent host when I was there last time. Yeah, I mean, as an answer to your first question, tomorrow morning at 9:30, you have me talking about acute stroke care trials. And so those of you who are here, why don't we wait till tomorrow on the streptokinase story? I will talk about that. But I mean, it's a tough haul. I mean, Anjum's there. She knows that if you give somebody a thrombolytic, they can have complications. So we'll talk about that a little bit more tomorrow. That patient selection is important. But I firmly believe, personally, I firmly believe, and I'm prepared to. Here's a challenge to the stroke faculty and to your colleagues across the country. I actually want to take a sabbatical and come there and work with you across the country to see if we can do a trial. I do personally believe that streptokinase is very safe in the right patients. So to answer your question, if you go back, and I'll talk about this a little bit tomorrow, that with the thrombolysis trials with TPA, the first trial was under 90 minutes. They had to go through 3,000 patients to pick 180 patients. So I do believe that you have to start off by cherry picking at the patients who are the best possible candidates, and then slowly and gradually improve your window where you can treat these patients. And I was also hoping to talk a little bit tomorrow, and I'd send you those two really seminal papers in the poly pill. I mean, I know somebody just like from Pakistan sent me some person who owns a pharmaceutical company wanted to. They're already producing poly pills. They're making pills with omeprazole, with aspirin, for example. They're producing pills of combination antihypertensive drugs. So adding a statin into that pill with the baby aspirin is not a big deal, but it's something that the Stroke Society in Pakistan would have to take up. I mean, like I said, I can come and work with you. I'm 65, so I can take sabbaticals or whatever. I can move around very easily, and I want to do that, but I don't want to do something where you come over and it doesn't materialize into something useful. Look at India. I mean, you have folks that you collaborate with. Two of our fellows down there are doing very large outcome trials, and very cheaply also. And there is funding. There's lots of funding from Wellcome Foundation and the WHO and in Pakistan. So I think polypill is the way to go. We can talk more about that. The way we usually work is that you would, and Zoom can make it very easy for us, that you take individuals from across the country and have a working group that can go back and do a small feasibility study and then go for it. So excellent questions. And it's really important that we do more than just emulate what the West is doing. Our problems in Pakistan are very different.
Okay, thank you very much.